Hi, it's Roger Green. This week, all our posted conversations contain completed contents from our year-end interviews, edited only slightly for flow and background noise. This conversation is with our good friend Jeff Lazarus. He describes 2022 as a tough year in healthcare where, as he puts it, everyone is overwhelmed coming out of the COVID-19 pandemic. However, he's far more optimistic about fatty liver disease, where the year has seen movement outside the liver space to diabetes societies and primary care meetings. Jeff notes that we will need what he describes as a drugs plus approach to address fatty liver disease, with the plus approach focusing on lifestyle effects and sustainable development goals. Just a reminder, Surfing the NASH Tsunami will have next day coverage of the 2 presentation days at NASH posting the Friday session around 6 p.m. Eastern U.S. Standard Time on Saturday, and the Saturday session around 6 p.m. Eastern U.S. Standard Time on Sunday. And here's Jeff. So we are now here with Jeff Lazarus. Jeff is in Barcelona the morning after a rather remarkable World Cup. How are you today, Jeff?
Jeffrey Lazarus.
Good morning, and thank you. Yeah, I'm good.
Louise, how are you this afternoon?
Louise Campbell.
I'm very well, thank you very much.
So basic purpose of the podcast is to talk 2022 and NASH and and fatty liver disease in general. And I know that a lot of your time has been dedicated to some really compelling and powerful work on COVID, but you spent a lot of time in NASH also, right? Between pathways and nomenclature, I think we had a lot of your attention this year. Lucky us. Your impressions of the year, sir?
Well, I mean, overall, obviously it hasn't been a great year for the world. We just did Inside Story for Al Jazeera about the big impending nursing strike in the NHS, strikes in Spain, problems with healthcare, which of course affects us in fatty liver disease. Everyone is overwhelmed. I mean, and we're out of the emergency phase, maybe, or getting out of the emergency phase on COVID-19, but we're still in the middle of a pandemic. In terms of fatty liver disease, I think things have been better. We have new prevalence studies. The data isn't exactly going to make us feel any better with, 1 in 3 adults now estimated to have fatty liver disease, but we have stronger studies. We have a better understanding. I think there's been good developments in engaging more with endocrinology. There's been some good reviews on the situation with general practitioners. But really, for me, the big thing is the community's coming more together and also recognizing that the community expands beyond the liver space. It means diabetes, it means obesity, it also means cancer.
So that's interesting because when I quote you, the line I most often quote is a line from the first time we talked, not even on the podcast, when you said hepatology needs to know they can't go it alone on this one. And I think a large part of 2022 has been about hepatology figuring out, well, they might have known that in the first place, but not having to go it alone.
Yeah, and I fully stand by that. I was a couple of weeks ago at the International Diabetes Federation conference for the first time. I know Jörn was at the European Association for the Study of Diabetes, I think, speaking there for the first time. We're starting to go to their meetings. We need to get them to our meetings. We need to understand the metabolic syndrome and not just our silos. I worked at WHO a long time. Everything was siloed. Even health systems was in a silo, not working with all the different conditions so well. And now we're seeing it again, but we're starting to make inroads to change that. And one of the big, for me, turning points was gathering again for a Wilton Park meeting. That's a think tank based in the UK. And instead of meeting online like we've been doing over the last couple of years, 45 of us were able to meet in person, and we had people from the obesity space, from the liver cancer space, even someone who had helped build a movement in HIV and could talk to us about what it's like, to really build a global movement that's inclusive and transparent and has, I don't want to say clear endpoints, that's too clinical, but certainly clear goals and targets.
Do me a favor then, distinguish, what's the difference between a clear endpoint versus a clear goal and target as defined in this context?
No, I mean, that there's no real difference. I was just kidding because, we're talking about clinical trials all the time, and endpoints is the language of the clinician. And in public health, we often talk about the sustainable development goals and then concrete targets. In viral hepatitis, we have a goal of elimination of viral hepatitis as a public health threat, and we have specific targets to reach it. So, we have an overall goal on fatty liver disease, right? I mean, we want to end this issue, but we have lots of targets along the way. More people diagnosed, better treatments, drug approvals, more people adhering to lifestyle structured interventions, and so on.
So I'm going to run with your theme, and I'm going to say that makes sense to me, and that endpoints are only A, one of those, and B, not likely to be met by a single drug, right? I mean, when we talk on the podcast about drugs a lot, we talk about the idea that over time therapy will evolve into something that looks a little more like drug therapy, will evolve into something that looks a little more like cancer with induction and maintenance, that there will not be one-size-fits-all treatment, but that because different patients present with different sets of issues, you'll need different kinds of medications, and you'll need some sophistication about how to use them. And then going back to where you started, we will also have the issue of you can't possibly get all this done in hepatology. So we're going to need the feeder system to work a lot better.
That's absolutely right. And, we can look to COVID that everyone, has lived experience with now. It wasn't enough to just vaccinate. The top priorities coming out of our paper, in the Lancet, in the Nature was, a vaccines plus approach. Vaccines may be the cornerstone, the same way maybe drug therapy will be the cornerstone for fatty liver disease, but we're still going to need to improve lifestyles, diet, and exercise. We're going to need general practitioners and nurses and nutritionists and dietitians to help and support adherence. This can't all be done from the hepatologist's office. And really, I guess the best comparison is to viral hepatitis. It moved out of hepatology into infectious diseases, into addiction centers. In Australia, it's even out of the GP office, prescribing DAAs and overseeing adherence. It's still in hepatology as well, but it will need to expand. And that goes back to what we both said about this is not an issue for hepatology alone, even if hepatology can lead.
You had Barcelona early in the year, and then Wilton Park in October. And where do you see that part of the effort coming forward in 2023? What do you see as the major accomplishments for 2022 beyond just getting people together, which is not trivial? And then where do you see it leading in 2023?
Yeah, so the Innovations in NAFLD Care meeting was a bit unique. You were there, so was Louise. It was a small group, but it included endocrinologists. It included people from, a few people from outside the liver space, but really thinking and, co-creating together what we need to do. So we will meet again, but it's not just about meetings. We won't necessarily have another Wilton Park meeting. We need to meet where there already are meetings. That's one thing we learned during the pandemic. We need to cut down on our travel. We will cut down on some, unfortunately, I think, on some of our face-to-face time, but for a lot of reasons that makes good sense. But now we need joint documents. We need to make that roadmap together. What does it mean for the world? There's no WHO strategy. There's no WHO action plan. There's no technical guidance. So there's a lot to do. Doesn't mean that there's no technical guidance out there, right? Professional societies have clinical care guidelines, but WHO needs to have their technical guidelines. Whenever, I've said this over and over, whenever they did this recently, publish their NCD technical guidance, there's no mention of the liver except to deliver on diabetes care and to deliver on cardiovascular disease care and so on. And it's not a competition, but you're not doing anyone, patients or people at risk, a service if you're not also mentioning the role of liver health. You're not providing, I would say, full and good care for people with diabetes if they're not aware that they're at risk of and actually have a very high likelihood of having liver fibrosis. So one of the things we discussed at International Diabetes Federation, the big diabetes conference, was people asked why in endocrinology should we even be testing people for fatty liver disease if there's nothing we can do? Well, there's a lot we can do, even without a specific NAFLD drug. There's actually a lot of drugs we are providing. We're getting their diabetes under control helps, and it can help people adhere to their diabetes medicine even better and take it even more seriously if they realize also their liver is at risk, also their heart is at risk, and so on. So, for 2023, it's about, consolidating more. It's getting that roadmap started. And one of the big projects we have is a research and action agenda. So a large group of almost 500 people from over 100 countries weighing in on what are the priorities in research and what are the priorities in action. This is just be a guidance document. You can still do whatever you want, but at least we'll kind of get ourselves on the same page the way we did with the NAFLD public health consensus statement to say, actually, this is a public health issue and a liver issue.
I think Jeff's been absolutely key in everything he's said. 2022 has been probably the biggest year that I've seen and continues to deliver on associated metabolic conditions coming to the table. We did a catch up with Naeem earlier on in the week, and he was saying when he assessed the AGA guidelines for NAFLD that only 9 to 11% of people need to be seen by hepatologists. I've commented before that most people have poor liver health. They don't have liver disease. So this whole thing about we only need to see what we need to see. But the American Association of Diabetes yesterday published their standards of care, and section 4 is all about screening for NAFLD now. So earlier on in the year, in May, the American Association of Heart disease acknowledged that NAFLD needs to be screened for, and it increases mortality in their population. So we have the big players now starting to recognise NAFLD and NASH as a real serious complication, co-founder and comorbid condition to theirs. And I think this is where we will start to move. So we need to have that real three-pronged development of all of the associations moving forward. And obesity, whilst the WHO themselves don't have an NCD for fatty liver disease, they did in the European obesity strategy say that NAFLD was the fastest growing non-communicable disease in obesity. So they have used the term. Let's get them to define the term going forward. The NAFLD strategy meeting in Barcelona was key, bringing some of those players together with the patient associations and Donna, because I genuinely get a sense of movement this year in that way. And that's great.
You mentioned, Louise, the AGA guidance, and of course that was published in gastroenterology. I believe it was also published in obesity and simultaneously in diabetes care and simultaneously in metabolism. So, these are signals to the members of these societies that this is for them too. In this day and age, you get a PDF and you look at the journal, but you don't just think about where it was published. But if it's your society journal, you pay particular attention. And the fact that this was published, in sort of 4 society journals is we haven't really seen anything like that in a long time. So the field is moving in that way. And like you mentioned, in Barcelona, a priority was to engage with the patients, with the community, and that's a big community. That means bringing diabetes, cancer, and obesity to the table. The things we did at Wilton Park, and I'm on the Public Health and Policy Committee at EASL, and it's also a priority for EASL now to engage more with the patients as well as the patient advocacy groups and really hear from them. And that's why last year you featured it, I know, on Surfing NASH, the patient guidelines we developed led by Sven Frank and others. And it's been great to see them being used and translated in a short version and the images and so on.
So convergence takes many forms. And one of the things I thought was interesting in the past year that we've never formally commented on this podcast was the formal alliance of the Fatty Liver Alliance of Canada and the European Liver Patients Association, right? Because you've now got organizations reaching across the pond and saying, we are patients wherever we are have the same issues. We have similar comorbidities. We have similar needs to deal with government and sustainable goals and those kinds of things. And therefore, we should all be aligned. I'm not aware of that happening in a lot of other diseases. I know they're international groups, but where national groups from different, not even the same continent, reach out to say, okay, we are one here. I thought that was kind of an interesting thing.
It's a great development. It's where the field needs to move. There's so many learnings they can share. Of course, that came after ELPA split into LPI and ELPA. I'd like to see a movement where people are working back together again. In hepatitis, the World Hepatitis Alliance grew out of what was back then ELPA and brings together representatives of national organizations from all over the world who then have regional representatives, and you can still work at the national level exactly the way you want to, but you have a forum to engage, and they have a nice conference, but they also have a lot of other things. So they work together on World Hepatitis Day, they report patient stories, they've collaborated on the Lancet Commission, bringing the patient voice. So the more we can see that kind of collaboration of patient groups, and if they can start to bring in diabetes and cancer and obesity in one way or another, formally or informally, I think it will be a huge advance for the field.
I was thinking exactly the same thing there with Jeff on the charities and the patient groups, is the fact that the word liver, again, in the diabetes or cholesterol or heart disease foundations, anything on the website, the only word that contains it is deliverance. So maybe we now have to ask their society heads to start publicising, because if a patient presents to their practitioner, whether it's their endocrinologist or whether it's their primary care physician or even their primary care nurse or diabetes nurse, and says, I've now been told or I've noticed on the website that they're asking for the screening for my liver, how do I go about that? Then we might start to again get the huge patient involvement, because I think a couple of years ago, if I'm correct, pancreatic and liver cancer took over vascular disease as the biggest comorbid condition in type 2 diabetes. And I think there's been very little focus on that within those areas. And having recently been out in Australia, they've got some great material all on diet and nutrition, but the liver is excluded from absolutely everything. So it's somewhere we can look to strengthen.
Yeah, I mean, last year we coined, to deliver on the liver and have a project with that name. And yeah, it's a little corny, but it's exactly what we need to do. We need to deliver on the liver. We need WHO to start delivering on on another condition. So it's great that they mentioned it once, but they should be mentioning it hundreds, if not thousands of times. Because I really do believe, what the EASL-Lancet Commission said, the liver is sort of a window onto society. And that's why we were developing that work around the Sustainable Development Goals and showing the connection between different goals and targets to the liver. Because if your liver is failing, you can really see how society's failing. Maybe there's not places for you to exercise. There's not safe, urban, green environments. You don't have good food accessible. And I was in this debate the other day and someone said, it's personal choice. And I said, it's not always choice if you don't have enough money. And someone in Spain was giving this data on a study in New York and Madrid, and it was fascinating. In the poorest areas of these cities, you have the highest concentration of shops selling the worst quality, right? The ultra-processed food closest to the schools. So the first place these kids come out in the poorest areas, the places that have the worst food. So it's not always about individual decision-making. There are structural things we can do. And one of the ways they decided to resolve it was they're not going to go in and close the shops, but they said no new shops selling that kind of food can be built within a certain radius of the school. And I think we need to be thinking out of the box. And anyway, the liver really shows us how society is not working for the most marginalized populations, for the poorest populations, and in so many other ways, because it's not just poor and marginalized populations who have liver problems or fatty liver disease.
Reminding me of the old idea from business school that people do what's inspected, not what's expected. We've had challenges with how do you inspect the liver? And then in the conventional medical sense, we've had challenges with what do you do about it? So I'd like to spend a couple of minutes looking at those from your perspective. Let's do the inspect first. The rise in non-invasive testing and work on ways to use non-invasive testing, particularly liquid biopsies and FIB4, which has its limitations, but is cheap. How important and how do you think that gets put to best purpose in pursuit of the kinds of things we're talking about here?
It's an absolute game changer. And I think most hepatologists would tell you they're really only doing liver biopsies when they absolutely have to, or, which includes clinical trials. But I would take a step back first. So what gets inspected, we don't have surveillance. When WHO started doing disease surveillance for HIV, for TB or malaria, and countries had to report and countries were compared, that's what I was referring to really in my first comment about the good news is we have prevalence data. It means there was enough studies for Dr. Younasi and for others to carry out these kinds of meta-analyses and tell us what's going on. Of course, the bad news was what we found out was that so many people have fatty liver disease, but we actually are getting more and more studies. So we do need that kind of inspection. In this case, I'd call it, monitoring and surveillance. Now, in terms of, individuals, the rise of NITs in our real world study in JHEP reports recently, just 35 participants reported using 14 different NITs with transient elastography and FIB4 being used most. And that's not a problem that they're using many different ones. I hope they're using them sequentially. I hope they're using some of them at the same time, because no one said, with a FIB4, you're making a definitive diagnosis. It means now you need to move quickly to the next test. But like you said, it's cheap. It's a calculator. It still takes some time to do, but we should be doing this in every person with diabetes, I think really in primary care throughout. And I know EASL and AASLD have different views on are we going to be testing risk populations or not, and what's cost effective. But given the numbers now of how many people have fibrosis, advanced fibrosis, and cirrhosis in the general population, I think we need to be getting much better at testing for it. And we need to raise awareness. And we need to, a couple of years ago, we were saying, the tsunami of everyone ending up in hepatology. Well, we deal with that with better risk stratification. A lot of these people are in care anyway, right? An estimated 55% of people with diabetes type 2 will have fatty liver disease. So they're in care. They don't necessarily need to go to hepatology, but they do need to be monitored. And NITs aren't well studied for, let's say, disease prognosis, but they will give us a lot of information. And we need to really roll out portable fibro scans and a better understanding of what NITs are available, what their costs are, how to use them.
So, Jeff, the other question, of course, is you now have Intercept refiling OCA with FDA, and Madrigal, I now will file resmetirom as quickly as possible. They announced that this morning when they released their data. How do you see the advent of meds, specifically targeted fatty liver medications, affect the processes that we're talking about here? I mean, it's clear what happens once you get patient in a hepatology office, but how do you think it affects everybody else in the treatment chain and in the disease chain?
I think it'll be just like what happened with HIV and DAAs. Because remember, when HIV was available in high-income countries, it wasn't in low-income countries and most middle-income countries. And as it became available, we saw more people being diagnosed. We saw awareness going up. We saw models of care changing, being developed. So you mentioned, we published an expert recommendation on models of care in Nature Reviews GastroHep in 2021, but we did one on HIV in 2010, showing new models of care for antiretroviral therapy. So as we get the new drugs available, there'll be new models of care. There'll be people more interested. Like I said, at the diabetes conference, when they hear that there's a drug, so for them, that means there's something can be done, they'll be more interested in it. What we need to do is make sure, and we'll really need the patient groups helping us, that doctors and clinicians are aware that actually you need to do a lot more than the drugs. There'll be a crucial role for nutritionists and dietitians, I think for GPs as well, because all of these people won't be able to be seen in hepatology. We'll need new collaborations like we had with suddenly GP prescribers of DAAs or nephrologists trying to eliminate hepatitis C in their nephrology department. We're going to need to be thinking, what are the new models of care? How do we improve communication? What does teamwork and multidisciplinarity look like? And we're moving in that direction, but incredibly slowly. The availability of drugs and the almost availability of drugs will really set fire to the changes that will need to come. So I think the Madrigal news and hopefully an approval of OCA, even if they're not widely available and even if they take a while to get approved, that news means that we need to start moving now and be prepared so that in a couple of years we're set. And that also means addressing the policy arena, making sure that policymakers, health authorities are aware that there's a potentially deadly condition that's highly prevalent and that there's a drug either about to be approved or that is approved, but the majority of people are undiagnosed.
Do we extend hepatology is currently the study of liver disease? Do we actually combine the method now that we actually look for poor liver health? And what we find is the percentage of liver disease that require hepatology and the level of poor liver health, which is often fatty liver, that is in that metabolic background. So by being more broad about what we're looking for means that we can take, it was to do particularly with your comment of make it cost effective. If we only look for liver disease, it is not cost effective to screen. If, however, or fibrosis particularly, if we do look for poor liver health, with 1 in 3 of the global population having probably fatty liver, Australia recently in a section of 77 people and 33% of those fit, healthy, relatively high socioeconomic group had liver fat with some concerning stiffness. So if we then make it about poor liver health and you only have to see 4 people to find 3 or 1, we've got a real numbers needed to treat becomes that much more effective. It's diet, it's lifestyle, it's dietetics, it's health and well-being, and it's making the patient or the person have ownership of their own condition and prevention. Because liver disease is the default for everybody currently, not good liver health. By broadening what we're looking for, we can make it highly cost effective in any blood biomarker with a serial FibroScan or ELF test to find the right population for each of the caveats, whether it's cardiovascular, endocrinology. We're looking that much earlier in the pathway, in the 30s, in the 40s, and preventing what most people think is inevitable because it's in their family, type 2 diabetes.
Yeah, this is about treating the person and not the disease. And we've had this so many times. We had this in HIV. Let's wait until their CD4 cell count drops, then we'll treat them. Let's wait with the DAAs until they're an F3 or an F4, then we'll treat them. HIV is test and treat. Hepatitis C is test and treat. Fatty liver disease is, well, it's not cost effectiveness to search for these people. Most of them don't have a liver disease or serious enough advanced fibrosis for us to do anything. What can we even do if they do? I think that's completely the wrong paradigm. People should know if they have fatty liver disease. They should know what may happen if they don't do anything about it and what they can do now. So that's awareness, that's education, and that's managing up to our authorities. It's also managing sideways, to all of our colleagues, and it's engaging. And that's where, it's crucial to have the patient groups of all stripes involved. When we talk to people, representing groups from obesity, they were very aware of fatty liver disease and they were very concerned about it. And I'm not sure if that's the case with all the diabetes groups. I don't understand why they wouldn't be concerned and want to know about it and want to prevent it from happening. They're already changing their diet. They're already on medication. So they're in the right direction, but they should be aware that there's actually another reason to take care of themselves.
I'm going to go back to drugs for a minute. Two sides of the same coin, or maybe the same side of two different coins. Not sure which. We'll see in a sec, right? So on the one hand, in less developed countries, we do have agents people could be using right now, right? We've got pioglitazone and PO and vitamin D have been proven to have some value. We have some diabetes drugs that have been proven to have effect. Some of the GLP-1s, and some of those might be affordable in some of those environments, even if not indicated, or in the case of PO, not promoted. So that's one side of the coin. The other side of the coin is, at least in the States, which is where I live, a large proportion of medical education comes from drug companies, which is good in that they teach doctors about diseases they need to know, but maybe not so good in that they teach remediation that's highly centered around expensive drugs. I'm wondering how you think that dynamic, the two sides of it, work when you get into the less affluent and poor, and then mid-range and then really low affluence countries on issues of fatty liver. I mean, how do you balance all that out to best effect, or can you balance it out to best effect?
Yeah, it's a really good point because, we've seen this everywhere, at least where I've worked in infectious diseases, that as drugs come to market and when they're on market, the pharmaceutical companies are covering a lot of that continuing medical education, awareness raising. But then we've had some pushback. So it was interesting when the government of England made an agreement with Gilead, that part of the agreement on purchasing their DAAs was that Gilead would support harm reduction centers. And, we can't just depend on pharmaceutical companies to take the bigger picture. After all, they're private companies, but there can be pressure put on them, not just through their CSR and not just through their foundation arms, but even in negotiating that they're going to work towards prevention, towards interventions that improve the condition, in this case, fatty liver disease, without the drugs, like the structured lifestyle interventions, but also, as a part of that, the drugs will be purchased. So I think, I think governments are going to need to think about this as they negotiate with the companies that come to market about what are they going to do if they're going to make large multi-million, maybe hundreds of millions of dollars in agreements. What else is the ask? They're going to be going for the lowest cost of the drugs. Companies will be going for the highest cost. But I think we need to be advocating that there's other issues that need to be on the table. And we have some examples, certainly from viral hepatitis.
So it's interesting. The Biden administration just passed in 2022 provisions that allow Medicare to negotiate drug prices for the first time in the U.S. So I'm wondering the degree to which that simply gets used to lower prices versus broad thinking in the way that you're talking about. I think right now school's out on that one. We're going to have to see how it develops, but it will be, I think, an important thing to think about, and maybe something for advocates to start to think about pushing the government to do that they might not be thinking about right now. They might not. I don't know. I haven't asked anybody yet.
I think it's an interesting one. If you look at what happened with Harvoni when Gilead brought it out, because the price was so high, it set up a black market around the world as to where you could get drugs. And because they signed a deal in Egypt for a whole course for $999, what happened was, certainly in London, where you live in Little Egypt, and a lot of patients were bringing in supplies. It provided a black market in the UK and around. It also drove the price back, but it also set up generics. They have to be careful, would be my caveat, because if you price it too high, you just push that to what happens, and you couldn't guarantee. We had to end up testing people with PCRs coming in on treatments that we didn't know what their treatments were, but we needed to see whether they were negative, so that it was actually a genuine drug, or was it? So it actually adds to healthcare and takes away resources. Focusing a little bit on Jeff's point there about the NHS and the UK, there was also a big pathway where all of the drug companies came in, and it was made very clear that they had to go out case find. So they had to provide resources into the primary care drug and alcohol settings to locate and assist us in location with patients, to take away some of that workload and to be able to triage in a better way. And I think Australia do have a very, very good model because of size, and I think this can happen in the US. We certainly had in 2003-06, when I was working there, a big shared care program where we would would run a lot of and look remotely online from our big centres in cities. And I obviously worked in Sydney, and look at and advise all the primary care physicians locally in places like Dubbo and Orange, and only see the patients once every now and again. Once you've upskilled primary care physicians, and that's the sort of thing that FibroScan going out into primary care can assist doing, is that you get that better network, you get that better trust, and therefore you can look at prescribing these medications with a good developed network and education. And I think there are lots of things to gain by a central system that the UK did. You take it at government level and you make sure it's devolved appropriately and spread throughout the country, not dissimilar to the way the Australians did it. But I think personally they have to be careful about how they price this and look at it, because it could just set more problems for us in healthcare.
I agree to some extent. I mean, with HCV drugs, this is curative. There were generic drugs in Egypt and other countries, as you mentioned. I don't know what generics will be available for fatty liver disease-specific drugs, or how aware people are that they would try and get it from another country where it's cheaper if they're denied in their own country, because there's a lot you can do. When you had hepatitis C, there wasn't much you could do, right? You either get the medicine or you hope your disease doesn't progress. With fatty liver disease, there's actually a lot you can do. So if you're that desperate, hopefully you'll turn to lifestyle interventions, and hopefully you've been given that advice, and hopefully you have even that opportunity to do it. I think the pricing issue is going to, I'm not an expert on this, is really going to come in when regulators and approval agencies are asking, well, how long are people going to have to take this? Is it the rest of their life? And will we be able to negotiate that after a certain number of years, the price might go down? And you remember in Australia, there was the so-called Netflix agreement on DAAs that if you treated X thousands, anyone else after that would get it for free. And so the Minister of Health made it very clear that everyone should try and diagnose as many people as they can over the next 3 years, because it would be less per capita. So it was a really nice agreement for everyone. But, the government realized that you're curing people, which is good. You're preventing onward transmission, which is incredibly important. So there were individual and public health aspects. In fatty liver disease, I think, in my discussions with, and I've had a few with regulators, has been like, well, is this about disease regression? Is it about non-progression? Is it about, going back a fibrosis stage? Is it the rest of their life? How much is it going to cost us? There's a lot of issues that other people will need to sort out. But if they come in too high, then, it's a negotiation. But if they come in incredibly high, it could take a long time. And remember, DAAs were not approved right away everywhere. We thought, wow, DAAs, every country's going to approve it and start treating. In 2017, when we did our European review, there were 2 European countries that still required F4. Turkey required a liver biopsy. This is for DAAs. I hope people are learning from what happened when other drugs got approved. Obviously, DAAs had incredibly high cure rates, so it was even more shocking that they were so inaccessible, and still are in a few countries.
Before we jump to the one list I want to cover, just a comment, which is that when DAAs became available in the States, I had Medicare directors screaming at me that they were the best drugs ever invented, and they would bankrupt state governments in a year at the price that Gilead was charging at launch. So, which is where all those controls came from, right? I mean, as you point out, if they had been priced differently, there might have been much faster access, and took some creativity to handle all that. Jeff, while we have you, for the last few minutes we have, I think I would be remiss if we didn't talk at least a little bit about the nomenclature process, because that's the other thing you've been involved in the past year that's, I think, really interesting and important. Interested in your reflections on that, and then I think Louise and I probably each have a couple of questions.
Well, firstly, it is a process, and it's a process that involves all the leading major liver organizations, representatives that they've nominated from more than 50 countries. It's been going on a while. It's a complicated process. It's not just changing the name or changing the initials. It's rethinking the entire nomenclature, understanding the role of alcohol and dual diagnosis, understanding, what do we mean when we say metabolic, and isn't liver health metabolic? Do we also need to call it out? Maybe yes, maybe no, but we need to discuss these things. It's not about unilateral declarations or one association or a small group of people saying, we've changed the name. And that's why, I'm very proud and humbled to be a part of a process that's being led by EASL, AASLD, and ALE. Apostle's been very involved to try and figure this out. Any minute now, and I mean literally any minute, we're going to launch round 4. So if not tonight, tomorrow, we have to get it out before the holidays. But the round 4 is, we're getting closer. And at AASLD, we presented transparently to everyone what's happened up to that meeting what the next steps are. There's a steering committee, a large steering committee. That's good. It's also one reason why it takes a while to get things done, because everyone has opinions. They're brilliant opinions. It's like a master course on fatty liver disease. I wish every student could see what's going on, because you have the world's leading experts, debating and discussing what's in a name, what's in a definition. And it's like chess, thinking down the line. If we take this name, if we use this definition, what happens? What does it mean for drug trials going on now? What does it mean for future drug trials? What does it mean for all the work we've done on NITs? So there's a lot of issues to be taken into consideration. And I'll just for the record say, I'm not saying anything that hasn't already been publicly said. I am in charge of the methodology, but I'm also following orders and just making sure we get this thing out on secure networks. We have a team we met earlier today that's sitting in New York that has nothing to do with fatty liver disease, but they're experts, in running Delphi processes. They ran the consensus statement for fatty liver disease and for the Nature paper on COVID, and ending that as a public health threat. We're very, very close to the next round. We will give people to just after the holiday to respond, so we won't be able to present it at NASH-TAG, but in January we will have the next round of results, and we should have some resolution. And without letting the cat out of the bag, so to say, I think everyone's going to be very happy. Not everyone, but almost everyone, because there's been a lot of considerations. Everyone's had a voice, and people have very varying opinions on this, but I think we're getting very close to a final nomenclature and name.
Just two questions, and then we'll go, because you've been really generous with your time this morning. Number one is, have you seen anything in this process that's really surprised you that you can talk about?
I've seen the field, debate and discuss in a way I haven't before. I mean, at a scientific conference, you ask a few questions and you move on to the next topic. We've been on the same topic now, long before I got involved, but certainly since this more formalized process started now, almost a year, we've been debating and discussing, and so many people have so many interesting and brilliant remarks. And I'm not just saying that knowing they're going to listen to this, but it's been incredibly engaging. Everyone is listened to. Every voice is truly respected. I really stake my reputation on that. I really believe it. So no one is shut out. In fact, a huge effort's being made by the chairs and by the associations to involve as many people as possible, because this is our field. And we're doing, again, in the end, we're doing our patients and future patients a disservice, because if we have to spend any more time on this, it's taking up a lot of valuable time from a lot of hepatologists, patients, and others. So, we need to sort this out. We need to respect the results, which I think will be the case when they come out. And I appreciate that the large associations are putting resources, both time and financial, to facilitate the process.
I just have one comment, because it's going out, obviously, as Jeff said now. Do you think, in light of Madrigal going for FDA approval for a fast track and a beta-cholic acid coming out potentially just before that, whether or not changing the name in light of that, where people understand it as NAFLD, depending on what happens with the nomenclature, might actually add some confusion to the world when it's going to be a drug that's approved for NASH and NAFLD in that context? And just as we're now engaging with cardiology and diabetes on the topic of looking for NAFLD in their guidelines and standards of care, do you think we risk derailing some of that, depending on what comes out of the nomenclature? And I know people have worked very hard. Just timing now.
I think it's a great question, and we've been talking about this all year. We only risk derailing efforts if we don't handle the process well. So this is going to be a big communications exercise. Remember, when the results come out, the name doesn't just change from one day to the next. The World Health Organization has to get involved, the additional classification of diseases. So there'll be a timing of when this happens and how it happens. There's going to be translations, which are not so easy for some languages. So it will be a longer process to switch it. And I think if we do it well, we can actually do a lot of awareness building, because we can reach out to the whole world and the societies and make this a big news item on the covers of journals and saying, this is the name. You may not have even known the last name, but you definitely need to know the new name. This is what it is. This is the definition. This is what you can do about it. And hey, maybe by the time this happens, we'll hear that a couple of drugs are about to be approved. I'm going to say about to, because we better have the nomenclature sorted before they are actually approved, because we know the FDA and the EMA have quite a long process, but we'll be able to hopefully package all of that together and have slide sets, information, translations, and bring that to the different societies in one big go, and hopefully in partnership with WHO. I'd love to see WHO an integral part of that, and that's how we really get onto their agenda of delivering the liver.
Jeff, thanks. This has been tremendous. Just great conversation, as always, with you, far-reaching, etc. Looking forward to having you back with us in 2023. Looking forward to seeing you in Barcelona in April, and which was a fantastic conference and something I would violently like to not to miss and to be able to attend this year as well. Not that I need to threaten you with violence. It's more about not doing violence to my schedule. But at any rate, so thank you so much. Have great holidays and Happy New Year, and we look forward to seeing you in January.
Well, thank you both, Roger and Louise. We're going to look forward to seeing you in Barcelona for sure in May 2023, if not before. And thanks again for having me on this, and have a great holiday when you get that far.
Thank you, my friend. Take care. Bye-bye now.
We hope you have enjoyed this discussion. Please join us again tomorrow for our final episode of 2022, including conversations with Stephen Harrison, Naeem Alkhouri, and Ian Rowe, here on the Surfing the NASH Tsunami podcast.